Thank you. Thank you. Thank you all so very, very much. Larry, thanks for that wonderfully kind and generous introduction. It is always great to be back with you. What a grand group of friends in this room, huh? You all are fighting the fight, and I commend you for it. I can't tell you how honored I am to be able to join you once again and be with such good friends. And it's always wonderful to be in the same room with Jane Orient. Jane has been a hero of mine, and we were kindred souls fighting the battle of Hillary care or Clinton care, whatever it's called. But the battle we've got right now, I promise you, is I think more difficult than what we fought back then. The challenges that we've got right now are astounding with this group of folks in charge, and I want to thank all of you for your tireless efforts at the state level in trying to get new folks elected to Congress and trying to get United States senators and what I believe will be the run-up to the most important election of our lifetimes. 2012 election, I believe, will be key in determining what direction we go in all sorts of different areas, but certainly in the area of health care. If this crowd is allowed to continue the oppressive action that they have taken against the American people as it relates to health care for another 4 years, it'll be at least a generation, if not longer, if we're ever able to recover. So thanks for the wonderful work that you're doing out there to make certain that that doesn't happen. That's the challenge that we have. I struggled with what to share with you because you've had a wonderful program, and you've had all sorts of folks who are telling you and sharing with you a perspective that is absolutely spot on in how to engage and how to move forward and how to make certain that we get to what I call patient-centered health care, which means it's pretty simple stuff. It means that patients and families and doctors are the ones that make medical decisions and nobody else. That's what patient-centered health care is, and that's what we ought to be about. And I want to talk a little bit about Obamacare and about the legal challenge where we are right now. I want to touch on fraud because it's the fight on fraud, which sounds, glorious and wonderful, is destructive to the ability to practice quality medicine. And I want to talk about the issue of quality, which is another buzzword that Washington bureaucrats and the left and others use to insert themselves into disrupting that patient, family, and physician relationship. Then I want to talk about some solutions, and we're going to do all that in a very short period of time, and then take your questions. But are you all on the CMS email distribution list? If you're not, you ought to get on it, because everybody needs a good dose of nausea every now and again. So, but these folks, my premise for this discussion today is that the federal government's out of control as it relates to health care, and if you all know that well. But if you didn't think so, I just picked up the last 2 weeks of releases on the CMS blast email. I'm on it. They'd take me off of it if they knew who I was, but. And they go on and on and on in all sorts of bad ways. This is just in the last 2 weeks, and I just got 2 of them sitting right here. HHS announces more seniors receiving free preventive care and discounts in the donut hole. HHS proposes broad patients' rights to access clinical laboratory test results reports. CMS releases guidance on the state balancing incentive payment program. Like they know anything about that, right? HHS launches Million Hearts campaign. $2 billion in Medicaid anti-waste measures announced by Vice President Biden at the last cabinet meeting. That gives you warm fuzzies. HHS announces 2012 Medicare Advantage and Plan D options. HHS launches comprehensive primary care initiative to strengthen primary care. CMS opens registration for third ACO Accelerated Development Learning Session and announces a Care Innovations Summit. Now, the common denominator, that's just the last 2 weeks. The common denominator to all of those is that CMS doesn't have a clue about getting to quality health care in our country. They don't have a clue. and yet they continue to promulgate all these rules and all these regulations in an attempt to try to get to what they say their goal is, but in fact their goal is control of patients and families and doctors making medical decisions. And that's where the battle is. That's where the battle is. So how does that reflect right now in terms of Obamacare and fraud and quality? Obamacare is the largest affront on quality health care in this country. It has allowed CMS and HHS to put forward much more aggressive activity in the private practice of medicine, in that quality relationship between patients and physicians. And they are moving with reckless abandon in terms of putting in place the kind of foundation that they think is necessary to enact this. Now, as you well know, there was a huge decision just made in the past couple of days by the administration, and that is not to appeal the 11th Circuit decision to the larger district court. And what that does is facilitate the movement of the case to the Supreme Court. Now, I don't trust these folks as far as I can throw them. So my sense was 2 and 3 months ago that we would have to fight as hard as we could to make certain that we got this case heard in this term, this upcoming term of the Supreme Court that starts on Monday. And so when they kind of step back and concede that it'll likely come up in this term, then I think, well, wait a minute, what are these jokers up to, right? Maybe they know something that we don't know about what's going to happen in the Supreme Court decision. I think this court is probably a 5-4 court in favor of the unconstitutionality of this bill. I think they'll find the individual mandate unconstitutional. However, the challenge that we have is if that happens, and if all they do is find the individual mandate unconstitutional, then as I suspect you've had others tell you, then we're still in a world of hurt. Because the guaranteed issue and the community rating and all the other nonsense that's included in that bill will still be standing, which is why the goal that we must work toward is to have Judge Vinson's decision be the one that comes out of the Supreme Court, and that is that recognizing that the individual mandate is the linchpin, the fundamental building block of the entire piece of legislation. And if you don't believe that the individual mandate's constitutional, then the whole thing absolutely needs to go away. So that's where we need to be from a legal standpoint. We touch on a couple different issues and then address a few solutions and then be happy to take your questions. The issue of fraud, medical fraud. Nobody in this room is in favor of medical fraud. I have no doubt about it. Nobody is. Nobody in their right mind is. But the problem that we have is that this administration and CMS and HHS are using the term fraud to harass practicing physicians across this country and to make it much more difficult for you to be able to care for your patients. And you all know that better than most, but I was given stark relief of that just this past week when my former orthopedic colleagues here in town shared with me a 2,000-page list of patients that CMS demanded information on in terms of billing to make certain that nobody committed fraud, right? So they went through this process, and you all know these kinds of stories well. 2,000 pages, and what CMS will ultimately recover if they do the right thing is about $834. $834. Now this isn't to ferret out fraud. This is to harass the practicing physicians so that he or she says at some point, as you well know, which is I think their final goal, okay, I give up. Just tell me where to sign and we'll be glad to be employees of whatever entity you want us to be employees of, and we'll be glad to do whatever you want us to do. Because it becomes so laborious and so tiresome and so frustrating just to do the administrative side of what the federal government is demanding. So when you hear fraud, and as you well know, the fraud in health care isn't physicians practicing medicine in a way that they ought not practice, or charging in a way that they ought not practice, by and large. Are there some bad actors out there? Yes. But the vast majority of fraud that's out there in the healthcare arena is somebody stealing a physician's number, provider number, and then stealing information on mostly Medicare patients, but oftentimes Medicaid patients as well, and then churning out the bills, churning out the invoices, getting paid until Medicare figures out what that something's going wrong, and it usually takes them weeks or months to be able to do that. And then they close up their storefront and move on and do the same thing somewhere else. That's where the fraud occurs in healthcare. It's not practicing physicians or patients out there that are defrauding the system. So please, you all know this well, don't buy into this notion that support of the federal government ferreting out fraud is going to result in a better opportunity for you to care for your patients, because it won't. It won't. All it will do is to increase your headaches. And then quality, the issue of quality. Everybody, I talk about the 6 principles of healthcare, with quality being one of them. Quality is the one that cuts right to the core of every physician's practice, because quality healthcare is what all of us want to practice, right? That's what every one of us wants to do. But the definition of quality, who's making the definition of quality, who's determining what quality is the fundamental question. So you'll hear folks in Washington talk about we want to make certain that we have a higher quality of care. CMS, HHS talks about it all the time. We want to make sure we have higher quality care. But that's their entree into dictating to you what you're able to do for your patients. And that's at the core of the Independent Payment Advisory Board, the denial of care board that was included in the Obamacare piece of legislation, and that they're moving forward with as rapidly as they can. And I want to share with you one concern that I discovered, that our office discovered last week. And Andy probably knows all about this. You all probably know all about this. But the quality improvement organizations, the QIOs at the state level that are supposed to ensure that quality healthcare is being practiced out there, many of them are run by physicians. They tend to be a place where most often you can appeal in an appropriate manner from a clinical standpoint. The QIOs, one of the provisions that has been included now in the trade adjustment agreement, this is, and I know this is a non sequitur completely, excuse me, I'm from Washington. The trade bills that are coming up for South Korea, Colombia, and Panama, they need a pay for, right? They need something that allows the administration to pound their chest and say we've protected American workers, when if they just did the right thing from a job standpoint, American workers would be just fine. But that's a topic for another day. But what they put in the TAA bill, we just discovered this last week, is a change in the definition of the QIOs, the Quality Improvement Organizations, and it is chilling. On first reading, I believe that the change in this policy, if it is adopted, already been adopted by the Senate, sits in the House right now, if it's adopted, would allow the Independent Payment Advisory Board to become the QIO for the country. For the country. What the policy change will do, if it's enacted, is to change QIOs from state level to regions, removes the peer review requirement in QIOs, and leaves up to the Secretary the sole authority of determining what the QIO will be in a given area, in a region or the nation. This is how destructive these folks are when it comes to the use of the term quality. They don't give a hoot about quality health care. They give a hoot about whether or not they're able to tell physicians what they must do and what they're able to do for their patients. So all of that is to say, this battle is massive right now, massive. I want to share with you a concern that I have about the general lay of the land from a political standpoint in Washington. We all know that the left is against us on this, right? All the nodding heads out there. Left's against us, always is against us when it gets right down to quality health care and patients and families and doctors making medical decisions. The center, because they believe that the government ought to be in charge of all that. The center, from a political standpoint, is questioning where they ought to be. They're not certain. They think that maybe that the government involvement, this repeal and replace that we talked about at our table very briefly, is repeal of this bill and replacement with something that's just a little less worse. Is that any better? No. Heck no. So the center's toying with that, right? And then I'm not proud to stand here and tell you that there are some on the right who aren't certain where they ought to be. So when you hear what's going on there, and you hear the discussion, even from the right, on the issue of fraud and on the issue of quality, if folks aren't talking about the imperative of patients and families and physicians to be the only folks that are making clinical decisions in this country, then they're in the wrong place. And that's your job. That's your job, is to get out there and beat the drums and pound on these folks to let them know that they can toy with health care all they want. But unless their fundamental principle is that patients and families and doctors ought to be making medical decisions, then they're barking up the wrong tree, right? So that's the challenge that we've got. Let me close with briefly with just a few solutions, because I'm an optimistic guy and I think we can get there, but you got to make certain that always in your quiver you've got some arrows that say this is what we ought to be doing. We introduced last week our Empowering Patients First Act for this Congress. It's now H.R. 3000. This is what was H.R. 3400 in the last Congress. And what it does is it provides for the opportunity or the ability of all Americans to gain the health coverage that they want for themselves, not that the government wants for them from a financial standpoint, through a series of tax deductions, credits, advanceable credits, and refundable advanceable credits, but makes it so that individuals own their health coverage regardless of who's paying for it, so that they have skin in the game and power in the equation. You got to get patients to be able to have power. That patient-centered health care, the only way to get to that is when patients have power. We solve the insurance challenges of portability and pre-existing by utilizing insurance for what it ought to be, which is to spread risk, so that millions of Americans, whoever you are, whoever anybody is, can pool together with others so that you get the purchasing power of millions, and thereby bringing it down so that everybody has the opportunity to purchase that coverage. We say, as a matter of law, that clinical decisions, medical decisions must be between patients and families and doctors as a matter of law. We're tired of fighting this fight. We need to state it in the law where those clinical decisions ought to be. And then finally, we've got robust lawsuit abuse reform in the bill. Not just a cap on non-economic damages, but a safe harbor for physicians who, if they do the right thing, given a certain diagnosis or a certain set of symptoms, that they know that they cannot be sued in a court of law unless it's a reckless, egregious activity. So those are the kinds of things that move us in the right direction. Finally, two other bills that I want to mention to you specifically by number. When you talk about workforce issues with the gurus up in Washington, and you say, look, the docs aren't going to tolerate this. They're not going to practice medicine under this design. They're simply going to quit. The guys and the gals my age, mid-50s, who understand what they have come through, are just going to say, that's it, I'm done, and the pipeline isn't full. So what are you going to do? You're going to have huge access problems. Their response is, if doctors won't participate in these programs, we'll force them. Now, they don't tell you that. Some of them do if they're honest, but we'll force them. And you say, well, they can't do that to me. And the response when you ask them, well, how are you going to do that? They're going to tie, their goal is to tie licensure, state licensure, to participation in these plans. And once if that's allowed to happen, then that is the death knell, I believe, for quality health care in this country. And so we got a bill, 969, H.R. 969, that simply says you can't do that, that is illegal to tie physician participation in any program, be it Medicare, Medicaid, the exchanges, or anything else, to licensure in a state. It ought to be illegal. And then the other one is the private contracting bill, H.R. 1700. If one free American can't enter into a contract with another free American who wants to provide a service for that first free American, they can't sit down at a table and say, I want that service, you agree to provide that service, this is the price upon which we agree for that service. If that isn't legal in the health care system in this country, and you got to force people's opinion on this, you got to get them to decide. But if that's not legal, then that again is another death knell for quality health care in this country. Patients ought to be able to contract with doctors. H.R. 1700. Those two bills, H.R. 969 and H.R. 1700, I believe to be the two key points to preserving the private practice of health care and quality health care in this country. Regardless of what else happens, if those two provisions are in law, then it makes it so that doctors can actually practice the kind of health care that they believe to be most appropriate for their patients. The challenge is we got to get folks not just on the left to recognize that. We got to get folks in the center and on the right to recognize the imperative of that. And they ought to stop playing footsie with the federal government when it comes to those grandiose ideas up in Washington about what you need to do for and with your patients. Thank you ever so much for the opportunity to be with you today. God bless you.
Time for a few questions?
Yeah, sure do. Yeah. I'm happy to take some questions. I'll call on them, or you can go. Hey, yeah. How about a bill to cancel the National Practitioner Data Bank? I'm for every piece of legislation that gets the federal government out of your back pocket and out of your exam room. The kinds of things that they have done to date, there's no evidence that the federal government has improved the quality of health care in this country. Whether it's through the practice of medicine, whether it's through the FDA, whether it's through every animal that they create decreases the ability of citizens in this country to get a higher level of quality of care. So I don't know that there is there a bill out there right now on that? I'd like to have one. There you go. Jane.
Dr. Price, I'd like to tell you my dream press release from CMS, that you guys would have to enact, of course, that would pretty much eliminate Medicare fraud totally, but also help deal with the problems of quality and access. That is to say, from henceforth, CMS reimbursement checks will be sent to beneficiaries only, not to providers, and the reimbursement check will be is reimbursement, it does not determine the fee.
Yes. Great point, Jane. The first part of that is a huge political challenge that even many in our camp don't support. The second part, however, is absolutely imperative, and part of that is what H.R. 1700 does, and that is divorce the notion that the federal government can set prices for physicians, which is just wholly incorrect and wrong. And 1700 divorces that. It may be appropriate for the federal government to say, this is what we will pay physicians for a service, or pay for a service that has been provided. But it is wholly improper for the federal government to say, this is what we will pay, and that's all that you can charge. That's one of the things that's gotten into us into this awful mess that we're in right now. Yeah.
Thank you for your remarks, and for, I think, exciting us about the possibilities coming forth, but also challenging us to get thousands more of us behind us and on the bandwagon. But maybe you can help me solve a conundrum I've been thinking about for the last couple of days. So most of what I'm hearing about alternative proposals involves tax deductions and credits and that sort of thing. On the other hand, most of what I'm hearing and makes sense about solving our economic fix is changing the tax code, eliminating deductions and all that sort of thing. So help me solve that conundrum.
You've identified one of the contradictions that is inherent in trying to work within the current construct of the law, and also having a vision for where we ought to be in the long run. I'm a huge supporter of the fair tax, the national retail sales tax, because I think it would align our form of commerce with our form of taxation, and it rewards all the things that we say that we want. However, if we get to that nirvana, then all of the incentives from a healthcare standpoint that I believe to be helpful at this point in getting folks covered go away. I'll accept that challenge. When we get to one or the other of those and we move to the next one, then we'll get creative and fix that as well. So one step at a time, one building block at a time.
All right, Dr. Lee Crisco from Minneapolis via Canada. First, a comment. There's only two countries in the world where doctors are disallowed from directly transacting with one another. They're Canada and North Korea. So it's probably not a good way to go. But my question to you is the appropriateness of tort reform at a federal level rather than through the states.
The issue of tort reform at the federal level is an important one, and I'm a strong believer that it ought to be primarily at the state level. The nexus that we take in our bill is to say any individual who receives any federal tax benefit or federal tax input into their purchase of health coverage or how they're supplied health coverage, then there's the nexus. For folks who don't have any nexus there, then they wouldn't be covered under that. And I strongly encourage states to adopt the kind of safe harbor plan that I have proposed. And when you think about it, that gets you Medicare, Medicaid, all of the self-insured plans, all of the ERISA plans get beneficial tax treatment under the federal government, and all of your federal employees. So you get virtually 85% plus of the individuals who are covered right now. That's the nexus. What I would work for is, again, having it adopted at every single state level so that you can do away with it at the federal level.
Richard Amerling from New York. Tom, we talked about the regulatory state, but also Medicare. A lot of us believe that Medicare does not have a constitutional basis. However, we are stuck with it politically, I'm fairly certain. What do you think about the Ryan plan? Do you think that has any chance of getting through?
The Ryan plan?
For Medicare, yeah.
The Ryan proposal, which is now the House budget proposal for Medicare, is to make it so that individuals under the age of 55 receive a benefit check, in essence, for the purchase of health coverage outside of the Medicare system. So it's basically a defined contribution instead of a defined benefit. That's where we need to move. And that's exactly where we need to be from a financial standpoint. The federal government will arrive at this conclusion if the right people are in place to make the decisions based upon the numbers. Because you can't, with the changing demographics in our society, run the kind of system that we're having right now without rationing care, without denying care to patients. I don't believe patients will tolerate that. But if and when that happens, we've got to have decision makers, policy makers in place who will move in the right direction, not to the other end of the extreme.
In 1996, Bill Clinton passed the Federal Tort Claims Act, by which it's allowed us to operate a free clinic without fear of being sued. And we see 3,000-4,000 patients a year for free. Is it possible, in exchange for just taking Medicaid off your back, for us to see the Medicaid patients for free? Would you extend our malpractice for our entire practice? That would balance your budget very quickly.
To the federal courts, you mean?
Yes.
Yes. Yeah. That's actually a proposal that's up there, is to provide only access to the federal through the Federal Tort Claims Act for Medicaid patients. This is a wonderful idea. I just learned of it, so I'm very excited. It's happening in New Jersey. Proposed in New Jersey. Yeah. Wonderful idea. And it's these kinds of creative solutions, again, that make it so that you remove the influence of government, either state or federal, into the practice of medicine, that are so important. And just imagine all the wonderful things that people could come up with if the government got the heck out of the way. And so I commend you for doing what you're doing.
Thank you, Dr. Price.
Thank you so much. I'll stick around for a little bit. Appreciate it. God bless you all.